Good morning. Thank you very much. So today I'm going to talk about right patient, right therapy, the medical management of inflammatory bowel disease in 2022. This is a very broad topic. I will try my best to finish this in 20 minutes. So what is IBD? It is a chronic, progressive, relapsing and remitting disease of the GI tract. It mainly consists of two diseases, ulcerative colitis and Crohn's disease. So ulcerative colitis, usually the inflammation begins in the rectum and it moves upward continuously. And usually the inflammation is confined to the mucosa. Whereas in Crohn's disease, it can affect any part of the digestive tract from mouth to anus. And there is transmural inflammation leading to fistula formation, stricture formation, and the inflammation is not continuous. There are skip lesions. So not only GI tract, there may be some extraintestinal manifestations as well. So there may be eye involvement, skin involvement, and the musculoskeletal system involvement and hepatobiliary involvement. And also some IBD patients are prone to develop thromboembolism. So if we let this inflammation to proceed without controlling, it can be associated with dreaded complications such as abdominal abscesses, fistula, and strictures. And also this uncontrolled inflammation can increase the risk of GI malignancies, and it can also significantly impact on patient quality of life, activities of daily living, and obviously it's going to increase the healthcare costs. And therefore, it is very important to identify these patients and manage their inflammation properly. So, a few words about pathogenesis. The exact cause of IBD remains unknown, and it is a complex interplay between multiple factors. Obviously, there is some genetic predisposition, and there's dysregulated immune response going on, and there are some mucosal barrier dysfunction. That is, their epithelium is more leaky than the normal healthy individuals, and there is a disturbance in microbiota, and there are some environmental and lifestyle factors such as diet and also smoking. So at the moment, most of our treatment focused on this dysregulated immune responses, and therefore most of our drugs are either immunosuppressants or immunomodulators. So what are the available management options for IBD? There are medical management options and surgical management options. Under medical management options, there are nutritional interventions, conventional medicines such as corticosteroid and immunomodulators, the biologics, biosimilars, and new small molecules, and fecal microbiota transplant. Under surgical management, we might need surgical interventions when there's failed medical treatment, when there are any complications, as well as we can use surgical intervention as a first-line treatment. For an example, if someone is having limited ileal Crohn's disease, this right hemicolectomy even could be curative. So this diagram shows key events in IBD drug development. The first effective drug was identified in 1955. It was cortisone. And in 2002, there was a major breakthrough. The TNF-alpha therapy, that is infliximab, was found to be effective for IBD. And in 2013, vidofludimus was introduced. In 2016, ustekinumab was introduced. And in 2018, the small molecule JAK inhibitors was introduced. And we can appreciate that during the last decade, there was a major expansion of the available medical options. So this was the traditional treatment approach for IBD, and sometimes we call this as a step-up approach. So in the past, when we encounter a patient with active IBD, first we started with less potent drugs, and if those drugs failed, we moved up to more potent drugs. So this may be still valid for a mild disease, but now we are generally moving away from this traditional strategy, because sometimes we encounter patients with moderate to severe disease. Of course, in them, these less potent drugs are not going to work, and we are just wasting our time, and we are risking patients' lives. So the time is important because there's a therapeutic window of opportunity. If we can diagnose and if we can initiate disease-modifying drug, we might be able to change the disease natural history or the progression. So individualized approach is needed. Right patient, right medication. So after the diagnosis, we should do a risk stratification, and according to that, we should select the right medication. So what are the current strategies aim for? So we have three main aims. So we should try to achieve deep and long-lasting remission, and we should aim to prevent complication, and we should aim to hinder the disease progression. In order to achieve this, in high-risk patients, we might have to introduce biologics and the combination therapy early in the disease course, and we need tight control and frequent monitoring of the inflammation. And if the patient is not responding, we have to adjust the therapy, which is called as treat to target strategy. So these are our goals. So our first goal is the symptom control, and our second goal is deep remission, and the third one would be the disease modification, which is coupled with tight monitoring. So these are our treatment targets. We have immediate target, intermediate targets, and long-term targets. So the clinical response defined as at least 50% reduction of symptoms is an immediate target. And of course, we can appreciate that going into the toilet 10 to 20 times per day is not so fun. So our immediate target is to achieve a clinical response, and clinical remission and biochemical response are our intermediate targets. The endoscopic healing is our long-term target, and in children, we should try to achieve restoration of normal growth. So these last two, the mucosal or the histological healing in ulcerative colitis and transmural healing in Crohn's disease, would be our ultimate targets. But at the moment, we don't consider those two as our formal therapeutic targets. So this is the same thing in a more graphical way. So it is obvious that one size does not fit all. So there are many factors to consider. So the first thing would be the underlying diagnosis, whether the patient is having Crohn's disease or ulcerative colitis. For an example, nowadays we don't use aminosalicylating Crohn's disease. So there's no point of prescribing aminosalicylate in Crohn's disease patient. And the second one would be the disease phenotype. Although we label a patient as a Crohn's disease, actually the Crohn's disease is a collection of several phenotypes. Some patients only have inflammatory disease. Some patients will have inflammatory plus penetrating disease. So the treatment depends according to the phenotype. For an example, if someone is having inflammatory Crohn's disease, we might be able to treat that patient just with corticosteroid and immunomodulators. But whereas in penetrating Crohn's disease and perianal Crohn's disease, we might need biologics and immunomodulators right from the beginning. So then the other factor we should consider is the disease severity, whether the patient is having mild disease or moderate to severe disease. And also we should assess the risk factors for poor prognosis. If those are present, we should go for more intense therapy from the beginning. And also presence or absence of extraintestinal manifestations are also important. The other thing we have to consider is age. For an example, in the pediatric population group, we try our best to minimize the corticosteroid use in that group. And there are also special patient populations such as pregnancy and elderly. In the pregnancy, we don't use methotrexate and we don't use tofacitinib. And in elderly, we don't use thiopurine because of the increased risk of malignancy. So also we have to assess the past medical history, especially the tuberculosis, hepatitis B, C, and varicella infection. And also we have to assess the medical compliances, because although rare, most of these drugs are associated with very serious complications. Therefore, the compliance of the patient is very important. And also we have to consider the socioeconomic status. This is not that much applicable to our country because of the free health, but in our country, we have to assess the availability of medication. There's no point of starting a million worth biologic if we can't continue it. And also we have to consider patients' concerns as well, such as needle phobia. So I was talking about poor prognostic factors. These are the poor prognostic factors for Crohn's disease. So younger age, smoking, longer disease duration, early use of corticosteroid, and the disease location, especially the upper GI Crohn's disease, is associated with poor prognosis. And also there are some other factors you can see. So, and these are the poor prognostic factors in ulcerative colitis. The younger age at the diagnosis, extensive colitis, severe endoscopic disease, previous hospitalization for colitis, elevated CRP, and low serum albumin. If these poor prognostic factors are present, we should go for a more intense treatment, which is also known as top-down treatment. So if someone is having a low risk ulcerative colitis, the initial therapy would be amino salicylate and or steroid. For Crohn's disease, it would be steroids or immunomodulators or a combination. So we should remember that steroids should not be used for longer periods of time. We have to taper steroids over 60 days to prevent withdrawals or relapse. The low risk patients who do not respond or lose response to initial therapy should be escalated to therapies recommended for patients with moderate and high risk. So for the patients with the moderate and high risk for ulcerative colitis and Crohn's disease, for both conditions, we can use either immunomodulator therapy or biologic or combination therapy. That is biologic plus immunomodulator. So, but in the initial stage, we might have to bridge with corticosteroid therapy because it might take some time to these drugs to act. So until that, we might have to bridge the treatment with corticosteroids. And then we should assess for remission. So what does remission look like? So there are clinical targets and biomarker targets and endoscopic targets. I'm not going into a detail of this slide. So what should we do if the patient is not in remission? Then we should optimize current therapy. To optimize current therapy, the therapeutic drug monitoring is needed, but unfortunately in our country, we don't have this facility. So after optimizing current therapy, we should reassess the response. If still there is no response, we might have to switch to a different therapy. And again, we have to reassess the response and adjust our treatment according to that. So we have to remember that there's no correct order of treatment. So now more details into the pharmacological interventions. Unfortunately, I might have to skip some slides due to the time constraints. So something about this budesonide. So this is a second generation cephalosporin, second generation corticosteroid, which has a very extensive first pass metabolism. Therefore, it has less adverse effect and better tolerability, and it is not associated with adrenal suppression or significant reduced bone mineral density. So both oral and rectal forms are available. So I will skip these next few slides. So biologics. So the biologics has revolutionized the management of IBD during the last 2 decades. As I mentioned, we have started using infliximab since 2020 and the other biologics since after 2012. So there are 2 main groups of biologics we use in IBD. First one is pro-inflammatory cytokine inhibitors, under which we have TNF-alpha inhibitors and interleukin 12 and 23 inhibitors. And the second class of biologics used in IBD is integrin inhibitors. Few words about anti-TNF therapy. So the overexpression of TNF-alpha can cause chronic inflammation and tissue damage. The most commonly used anti-TNF therapy is infliximab and adalimumab, which is available in our country as well. And we might need to use a combination therapy, that is anti-TNF plus immunomodulator, that could be azathioprine or 6-mercaptopurine or methotrexate, because it has been shown that this combination therapy yields best outcomes because it is associated with highest response rates and lowest rates of neutralizing antibodies and lowest rates of loss of response. Infliximab, this is a chimeric antibody. It means this is derived from both human and mouse and DNA. So this has a relatively high immunogenicity. Therefore, if we use infliximab, it is best we can combine it with the immunomodulator. So this infliximab is approved for both Crohn's disease and ulcerative colitis. We can use it in steroid-dependent or resistant disease, and as a second-line treatment when the conventional medicine fails, or as first-line treatment in moderate to severe disease, and also as a rescue therapy in acute severe ulcerative colitis. We have to use loading doses and maintenance doses. So the loading doses we give at week 0 to 6, and from 14 week we give maintenance doses 8 weekly. So if there's loss of response, we might have to either increase the dose or to reduce the dosing interval. This is infliximab has a very quick onset of action. So efficacy is usually seen in 2 weeks, and the median time for fistula closure is 3 months. But we should remember the primary there may be primary non-responders, which could be higher up as 40%, and there may be secondary loss of response after 1 year. Again, it can range from 23 to 46%. Adalimumab is the second anti-TNF, which is commonly used for Crohn's disease and ulcerative colitis. This is given as subcutaneous injections. Again, the loading dose from week 0 and week 2. Then from week 4, again, we have to give subcutaneous injection fortnightly. And if there's a loss of response, first we can increase to weekly dosing. As I mentioned earlier, the therapeutic drug monitoring should be done during anti-TNF therapy. And this chart shows how to guide our treatment according to the drug concentration and the presence or absence of anti-drug antibodies. So the anti-integrin therapy, and we know that integrin is a cell surface glycoprotein receptor which mediates the homing of leukocytes into the surrounding tissues. So by using anti-integrin, we can prevent lymphocyte migration to the intestinal tissue. The most commonly and the currently licensed anti-integrin therapy is vidofludimus, which can be used in both ulcerative colitis and Crohn's disease for both moderate to severe disease, both in previously biologic exposed patients and also biologic naive patients. So this is effective for inducing, for both inducing and maintaining the remission. And we should remember that this has a because this could take some time to act. So the full response might take 2 to 3 months. So until such, we might have to bridge the treatment. And one good thing about vidofludimus is it is gut specific. So the risk of opportunistic infections are less with vidofludimus, and also the cancer risk is less. The other category is anti-interleukin 12 and 23 therapy. And interleukin 12 and interleukin 23 plays an important role in the cytokine storm, which can be found in the IBD. So the most commonly used anti-IL-12 treatment is ustekinumab. It is a fully humanized IgG1 monoclonal antibody. Therefore, the immunogenicity is relatively less, and we can use this for moderate to severe Crohn's disease and ulcerative colitis. This is beneficial in patients who are having psoriasis and IBD, and interestingly, some patients develop psoriasiform rash when we treat them with anti-TNF. So in these kind of patients, the ustekinumab is beneficial. So this is the most latest innovation. So the new small molecules, JAK inhibitors. The JAK inhibitors can block multiple signaling pathways, and the main benefit of this is we can administer this orally. So it is more convenient for the patient, and there's no need of hospital admissions. So tofacitinib is licensed for ulcerative colitis, and we usually start the treatment with 10 milligram twice daily for at least 8 weeks. After 8 weeks, we should assess the response. If the patient has responded, we might have to we might consider to reduce the dose to 5 milligram twice daily. If not, we will continue the 10 milligram twice daily dose until the week 16. If there's no adequate therapeutic response, we'll have to stop the treatment. So two main adverse effects of tofacitinib is herpes zoster and thrombosis. So especially the pulmonary thrombosis. So there are very interesting emerging treatments. The first one is apheresis therapy, in which we try to isolate and absorb one or more specific leukocytes in the peripheral blood, but these are still in the research stages. And also we can try stem cell transplantations. The most commonly used stem cell transplantation method is hematopoietic stem cell transplantation. And also since 2019, the research being conducted combination with combining two different biologics with different modes. For an example, there are research being conducted with adalimumab and vedolizumab for ulcerative colitis. And also there are various studies being conducted with fecal microbiota transplant in ulcerative colitis, mild to moderate ulcerative colitis, but now there are some black box warning against that fecal microbiota. So therefore, it is these methods are still not in guidelines. So these are my take-home messages. IBD is a complex and heterogeneous group of diseases, and we have to decide on the treatment according to the disease severity and risk. And we have to start effective treatments early, and we have to treat to target, and we have to do tight monitoring for response and for potential complications. And according to the response, we have to optimize the treatment. And please note that my presentation was based on the BSG guidelines and the American College of Gastroenterology guidelines. And thank you very much. I would like to thank the CCP and the Sri Lankan Society of Gastroenterology for giving me this opportunity. And if there are any questions, I would like to take those now.
Thank you very much, Dr. Thalagala. We haven't received any questions yet.
And that's all right. Okay.
In the interest of time, we will move on to the next talk. Before that,
Okay,
on behalf of Ceylon College of Physicians, I would like to hand over the certificate of appreciation for giving us a talk on update on management of inflammatory bowel disease. Thank you.
Very much.